Yes, we are all set to have another session on pediatrics. Everything is ready with us. And we are honored to have Dr. Ashutosh Aggarwal with us today, who will be taking the topic of pediatrics and share his insights and experiences with you. Dr. Ashutosh Aggarwal has done his MBBS and post-graduation from PGIMS Rohtak. He has further done fellowship in neonatology and also additional diploma in adolescent health. His clinical experience includes handling all types of patients from neonates to adolescents, now also supervising Project Chaitana, Early Intervention Center. We welcome you, sir. Let's start the session with our esteemed faculty, Dr. Ashutosh Aggarwal, the emphatic faculty. Over to you, sir.
Hello all students. Now time to discuss some topics of neonatology, intrauterine infection, genetics. Right? Good evening everyone. Good evening. Good evening. Right? A very good evening to all of you. So here I am. We'll be discussing the topics of the neonatology here. Yes, upon time upon laega. Definitely. Okay. Namaste and good evening. We start with the first topic of neonatology, and first I'm talking here regarding the neonatal resuscitation. And my first slide says just where, in which conditions do we require the positive pressure ventilation, and in which conditions we require the continuous positive airway pressure is. So if a newborn is having apnea, that is the first condition, or there is gasping, or the heart rate is below 100 per minute, in all these three conditions you need to monitor the SpO2, and also you need to start the positive pressure ventilation. And whenever we say positive pressure ventilation, what we mean is bag and mask ventilation. Bag and mask ventilation. On the other hand, if a newborn is having the labored breathing or persistent cyanosis, in that scenario, you need to go for the continuous positive airway pressure, right? And the second thing, how do we monitor basically in a neonate? All the monitoring in a neonate is done by the heart rate, right? It is always done by the heart rate. Moving on to the next thing. You have started the positive pressure ventilation, and whenever you say positive pressure ventilation in the newborn, you always mean is bag and mask ventilation. If after 1 minute of effective positive pressure ventilation, the word should be effective. The effective, what it means is it is moving the chest. Still the heart rate is less than 60 per minute, you go on to the chest compression. And when you give the chest compression, the ratio of the chest compression to positive pressure ventilation is 3:1, and it is to be given every 2 seconds. It is not given every 1 second, it is given every 2 seconds, one of the potential MCQs which can definitely be asked, right? Because 3:1 already has been asked. Now we are talking here is particularly every 2 seconds. When you are giving the chest compression, you are always giving is 100% oxygen. They might confuse you by giving a preterm child. You might start thinking on the retinopathy or prematurity, but chest compression is a life-saving thing. The concentration of oxygen is 100% here, 100%, right? When you are giving the chest compression, we are using the two thumbs technique, and that is particularly given from the head of the bed. So where should be the person who is giving the chest compression stand? He should stand by the side of the head of the bed. Both of the thumbs are placed on the lower third of the sternum with the hands encircling the chest, right? And when you're applying the chest compression, how much the anterior-posterior diameter is to be compressed? So approximately 1/3 of the anterior-posterior diameter of the chest is compressed. So So this is something which is important to be remembered regarding the chest compression. The ratio to be given every 2 seconds is. Moving on to the next thing, you have given the chest compression, still the heart rate is less than 60. What you go for is basically, you go for is the epinephrine. You go for the epinephrine. And epinephrine can be basically given by the three routes. It can be given by intravenous route, it can be given by intraosseous route, or it can be given by intratracheal route. That is intratracheal route. In the intravenous or intraosseous, the dose is 0.2 ml per kg. And if you are giving it by the endotracheal route, the ratio is 1 ml, the dose is 1 ml per kg. Right? Now the important thing what you need to remember is what should be the position of the endotracheal tube. The tip of the endotracheal tube, it should be 1 centimeter above the carina. The basically the tip of the endotracheal tube, it should be 1 centimeter above the carina, and if the carina cannot be visualized, then the position of T2 to T3 is adequate. This is something important you need to remember. Where should be the location of the endotracheal tube is. And when you are giving this epinephrine, remember, if you are giving by intravenous or intraosseous route, this is always followed by flush with 3 ml of normal saline. Flush with 3 ml of the normal saline. And you need to repeat it every 3 to 5 minutes if the heart rate remains less than 60 beats per minute. So what according to me in the neonatal resuscitation is important, the indications of bag and mask ventilation, indications for CPAP, regarding chest compression, regarding epinephrine. But when you are giving it by the endotracheal route, you need to administer positive pressure ventilation, but no flushing is required. Flushing is basically required only particularly in the case if you are giving by intravenous or intraosseous route is. Right? The second point what we have said here is particularly you can give by the intravenous or intraosseous route. So if a simple question comes, the question can be like this. If required during neonatal resuscitation, epinephrine is given by all of the following route except. Right? Can we have the answers from you? The neonatal resuscitation, epinephrine can be given by intravenous route. It can be given by intratracheal route. It can be given by intraosseous route, but it cannot be given by the intra-arterial route. Right? So simply questions, epinephrine is not given by the all. You all are correct, right? Going on the right tracks. Very, very good, all students. Clear. Then when you are doing the SpO2 monitoring in a newborn, that is always done from which limb? The SpO2 monitoring in the newborn is always done from the right upper limb. Right upper limb. That means we go for the preductal SpO2 monitoring. You want is basically the preductal SpO2 monitoring. If you consider like this, let us suppose we are talking the heart here. This is particularly your aorta here. This is here your pulmonary artery, and this is the ductus arteriosus. So you basically want to monitor from this portion of aorta which is getting directly the blood from the heart, and this would be supplying the right upper limb, right? So always you are monitoring this from the right upper limb is, and here at 1 minute it is 60 to 65. Here you add 1 minute, here you add 5%, it becomes 65 to 70. This is 70 to 75, this is 75 to 80, this is 80 to 85. So up to the 5 minutes, you are just adding 1 minute, and here you are adding the 5%. So it goes particularly like this. And then at 10 minutes, it should be 85 to 95%. And the lastly here in the resuscitation, what we remember is if there is no heart rate at birth, what should be the minimum duration of resuscitation required? The minimum duration of resuscitation required is for 20 minutes. 20 minutes, right? So this is just, we have done the important points to be remembered in the neonatal resuscitation, right? So if there is no heart rate, the minimum duration of resuscitation, it has to be for the 20 minutes. Yes. Then we going on to the another important thing, hypoxic ischemic encephalopathy. We are talking of HIE, hypoxic ischemic encephalopathy, and what we have taken here is basically we have taken here neuropathological changes. What I basically want to correlate is what can happen in the damage to the brain and what will be the clinical features will be. So if we consider here in the preterm child, this causes periventricular leukomalacia, which we call PVL. And this periventricular leukomalacia mainly affects the fiber supplying the lower limb. So this results in which type of cerebral palsy? This results in the spastic diplegic type of cerebral palsy. Spastic diplegic type of cerebral palsy. In a term child, this can particularly result in the status marmoratus. And this status marmoratus mainly affects is the basal ganglia. This affects is the basal ganglia. And if this affects the basal ganglia, which type of cerebral palsy we are going to get is chorioathetoid type of cerebral palsy, right? So the most common cerebral palsy in a term child due to HIE is chorioathetoid type. In a preterm child is spastic diplegic type. Apart from this, there can also be parasagittal cerebral injury. And this parasagittal cerebral injury will result in the spastic quadriplegic type of cerebral palsy. So just a clinical correlation of the neuropathological findings, what we get there is, right? Yes, of course, chorioathetoid type, this can be also called as dyskinetic type. This can also be called as the extrapyramidal type. This can be also called as the extrapyramidal type, right? So this is basically dyskinetic, extrapyramidal, as there is no involvement of the pyramidal tract. Then we need to remember here what are the causes of neonatal seizure within the first 24 hours of life, within the first 24 hours. So first 24 hours, the cause can be HIE, cause can be hypoglycemia or hypocalcemia, cause can be sepsis or meningitis. This can be subdural, subarachnoid or intraventricular hemorrhage, intrauterine infection, pyridoxine deficiency, drug effect and drug withdrawal. And out of this, what can be the questions is, which is the most common cause of neonatal seizure? Overall, if you consider, the most common cause is hypoxic ischemic encephalopathy. Hypoxic ischemic encephalopathy. What is the most common cause in infant of diabetic mother of neonatal seizure? Your answer is hypoglycemia. Hypoglycemia is the most common cause in infant of diabetic mother. What is the most common cause of neonatal seizure in a preterm child? In a preterm child, the most common cause is intraventricular hemorrhage. Intraventricular hemorrhage. You're all giving very right answers. Really good. Right? Then drug withdrawal. Drug withdrawal seizures in India can be seen if the mother is using selective serotonin. Selective serotonin reuptake inhibitors. Selective serotonin reuptake inhibitors during pregnancy. In India, drug effect is most commonly with the drug withdrawal, right? So we are saying here is like this. This is the selective serotonin reuptake inhibitors, right? Moving on to the next things, I will be fast here. Neonates with the acute respiratory distress, here just we are discussing is the chest x-rays. In the respiratory distress syndrome, that is the hyaline membrane disease, what we get is the ground glass appearance or air bronchogram. Second is transient tachypnea of newborn, which is also the most common cause of respiratory distress in a term child. In a term child, and what you get in the TTN is fluid in the intralobar fissure or the prominent perihilar vascular markings which give you the sun ray appearance. In the meconium aspiration syndrome, the most common finding is patchy infiltrates. This is the most common finding. Apart from this meconium can result in the partial obstruction of the airways, which will lead to the emphysema. So you can get is increased anteroposterior diameter, or you can also get is the flattening of the diaphragm. Just the 3 X-rays what we want to say. In this, I have just tried to cover what is the investigations to be done in the neonatology in the various conditions. In the hyaline membrane disease, you can go for chest X-ray. But in a atypical case, right, you go for tracheal aspirate. Just like if you want to know the lung maturity, particularly in the before pregnancy, you measure lecithin sphingomyelin ratio in the amniotic fluid. The same thing you can measure in the tracheal aspirate, that is lecithin sphingomyelin ratio, and also phosphatidyl glycerol. Then is for PPHN. The PPHN, the investigation of choice is real-time echocardiography. Then is congenital diaphragmatic hernia, and that is a condition which can be diagnosed even prenatally. So if you consider prenatally, your answer is ultrasonography. And if you consider after delivery, your answer is chest X-ray. Your answer is particularly the chest X-ray. For diagnosis NEC, necrotizing enterocolitis, it is plain abdominal X-ray, which is more than ultrasonography. To diagnose the hypoxic ischemic encephalopathy, we go for the MRI. Intraventricular hemorrhage, we go for the cranial ultrasonography. Meconium plug syndrome, you should always choose gastrographin enema more than anorectal manometry. Because gastrographin enema is not only diagnostic, it can also be therapeutic. So you will always choose gastrographin enema, both diagnostic and therapeutic. Then is neonatal seizure, and that is the gold standard is the conventional EEG. Amplitude integrated EEG, that is AEEG, you might find used, and this is used only as a screening tool. This is not used for confirmation. The gold standard to diagnose the neonatal seizure is the conventional EEG. ROP, retinopathy of prematurity. What is the investigation of choice? Right? Basically, how do you diagnose? Nowadays, you go for wide field digital camera, which is also called as the RET cam. Right? This is indirect ophthalmoscopy was previously used. Now we are using is particularly here the RET cam is. So in these 2 slides, basically I have tried to cover all investigations will be required in the various conditions in the neonatology. Now I want the answers from you. Radiographic study to detect specific neurological finding. For IVH, what we are using is. Questions will be there. Wait, questions I will be discussing. For IVH, what we are using is cranial ultrasonography. Very good. Cranial ultrasonography. For HIE, what we are using is HIE. We are asking the radiological investigation. It is MRI. Right? For subdural hemorrhage. For the subdural hemorrhage, what we are going for is subdural hemorrhage. You are going for the CT scan. Cerebellar hemorrhage. We are going for is again what is for the CT scan. Right? NCCT, of course it is NCCT only. We have got the 4 conditions, and which all we are using, we have summed up here is. Right? And you have given the perfect answers. Very good. Great going everyone. Right? Now again here a important topic NEC. I have chosen NEC specifically because NEC already the questions have been asked in the NEET PG exam, and it's a very important considered to be a topic of NEC. Right, in NEC first we remember here the systemic science, and the systemic science we can remember by here in the stage 1A, 1B and 2A by BAT, where B stands for bradycardia, A stands for apnea, T stands for temperature instability. Right, here it also remains the same, here it also remains the same. In the 2B, this BAT changes to MAT, and MA means metabolic acidosis and T means thrombocytopenia, which has already been a repeated question. Thrombocytopenia is seen in which stage? So thrombocytopenia is seen in stage 2B. Then 3A you can easily remember by A and D. A and D, where A stands for acidosis, N stands for neutropenia, D stands for DIC. Right? So you can remember like this: BAT, MAT, and particularly here the A and D. Then particularly the signs, if you want to remember, here occult blood, here we say gross blood, here is absent bowel sounds, and here it is definite abdominal tenderness, and you need to write here is the right lower quadrant abdominal mass. Right lower quadrant abdominal mass. Right? Why right lower quadrant abdominal mass is there? Because the most common part of intestine affected is the terminal ileum and the ascending colon. Right? So this terminal ileum and ascending colon will result in the right lower quadrant abdominal mass. And here you get in the 3A and 3B peritonitis is present. And if you go for the X-ray signs, pneumatosis intestinalis. Pneumatosis intestinalis, that is seen in the stage 2A. And in the 2B, what we get is the presence of gas or air in the portal vein with or without ascites. A small table, but it is an important topic NEC to be remembered. So you will be able, definite ascites is stage 3A, definitely it is 3A. Right. Moving on to the next one. Now this is a table of the neonatal jaundice, and we have given you here what is the causative cause of neonatal jaundice according to the time of presentation. Child is presenting within first 24 hours after birth. That means this is always pathological. This is always pathological, right? So if we say pathological, this includes RH incompatibility, which is the most common cause in India of neonatal jaundice in the first 24 hours. ABO incompatibility, G6PD deficiency, hereditary spherocytosis. Then is breastfeeding, which is now called as breastfeeding failure jaundice, right? Breastfeeding failure jaundice. Physiological jaundice will always present after the 24 hours. So this can be the cause. Polycythemia can be the cause. Cephalhematoma can be the cause. Prolonged jaundice beyond 2 weeks can be biliary atresia, but in the biliary atresia, there will be increased in conjugated bilirubin. Then there is hypothyroidism, neonatal hepatitis, and please make a correction here. Instead of breastfeeding jaundice, it is the breast milk jaundice. Please make a correction here. This is the breast milk jaundice here, right? So we say here this is basically the causes of jaundice according to the time of presentation. According to the time of presentation. So if we go to now, the important topics are two. One is the breastfeeding failure jaundice and one is the breast milk jaundice. And we basically need to differentiate between the two. This breastfeeding failure jaundice is usually seen in the first week of life. But this breast milk jaundice is usually seen in the second or third week of life. Second or third week of life. Now why there is breastfeeding failure jaundice? Mother is giving insufficient breast milk. Child is having suboptimal feeding. So this will result in the increased enterohepatic circulation. Here also there is increased enterohepatic circulation, but this is due to beta glucuronidase, which is present in the breast milk. In the breastfeeding failure jaundice, now the mother is giving less of the feed. So will the child be able to gain the weight? So this is associated with the weight loss. But in the breast milk jaundice, there will be good weight gain, right? Now, one thing which question might be asked is, mother is giving less feeds to the child, which type of dehydration can be seen? And you need to remember the answer here, hypernatremia. Hypernatremia, right? This is important. One of the MCQs it can be asked that if the child is not getting proper breastfeeds, what all can we get is, what we can get is the dehydration, and this dehydration will be hypernatremic dehydration, right? So by this table again you can differentiate many of the questions regarding to them. Now this again is basically a picture how to go in a case of a neonatal cholestasis. Cholestasis means the bile is not reaching the duodenum, so there will be increase in the conjugated bilirubin. And what is pathological? The pathological conjugated bilirubin is more than 1 milligram per deciliter. More than 1 milligram per deciliter. A child comes to you, conjugated bilirubin is increased. What is the next step to be done? Next step is to look at the color of the stool. You can get the pigmented stool, you can get the pale stool. If you get the pale stool, you start thinking on the lines of biliary atresia. You think of pigmented stool, this is not biliary atresia. So if it is a pigmented stool, you go for ultrasonography, and you also go for the gamma glutamyl transpeptidase. You go for the gamma glutamyl transpeptidase, right? And if you differentiate them here particularly, this can be low or normal GGT, or it can be increased GGT. So if it is low or normal GGT, particularly the two causes are there. They are PFIC1 or 2. Progressive familial intrahepatic cholestasis 1 or 2. And if this is high GGT, it is PFIC3, which already has been repeated question, right? The neonatal jaundice, you are being given a picture, GGT is increased, and the answer to that was PFIC3. Now, if you get the pale stool, you start thinking on the lines of biliary atresia. Biliary atresia. So what is the first investigation to be done? That is for confirmation, liver biopsy. Liver biopsy. That is used for the confirmation, and that is the first investigation. You will go for liver biopsy, you will go for ultrasonography, right? HIDA scan is now plus minus. And if there is biliary atresia on biopsy, you will go for the Kasai surgery. You will go for is the Kasai surgery. But if the liver biopsy does not tell you anything and there is non-excretory, this is non-excretory HIDA, you go for peroperative cholangiogram. So if somebody asks you what is the gold standard for diagnosis of the biliary atresia, the gold standard now is peroperative cholangiogram. The gold standard now is the peroperative cholangiogram, right? So this is just a slide for the biliary atresia. Now what you can get here is a child is having the increased unconjugated bilirubin, plus there is spherical shaped RBCs, in the direct Coombs test is negative. What you should think of? If it is negative, that means antibodies are not there. So you should think of hereditary spherocytosis. But if there is spherical shaped RBCs and direct Coombs test is positive, if it is positive, that means there is antibodies which are present against the RBC. So this can be hemolytic disease of the newborn, which we particularly say erythroblastosis fetalis. That is RH incompatibility, or that is ABO incompatibility, right? And please, one more correction here. Instead of echinocytes, please write here acanthocytes. Please make a correction there. Instead of echinocytes, make it acanthocytes. And if it is acanthocytes present and there is increased unconjugated bilirubin in a newborn, you should think it of the pyruvate kinase deficiency. Pyruvate kinase deficiency. So just a picture. The same I have taken from the textbook of Nelson. A table is being given, abnormal shape of the RBC. There is jaundice. You can easily come to the conclusion what can be the answers in the neonatology. Right. Going on to the next one, the famous picture here, KMC. We all know, given particularly to reduce the hypothermia, and we are talking here the three components of the KMC. So the first component is the KMC position. First is the KMC position, right? And that basically means is the skin to skin contact. Skin to skin contact. Then what is the second component? The second component is the KMC feeding. That is basically we say is the exclusive breastfeeding. Exclusive breastfeeding, right? And what is the third component? As soon as the delivery takes place in the hospital, what does the patient wants next? The patient wants is the discharge, right? So what you will say to the patient, I will do the early discharge, but you need to come for the follow-up. We give for the early discharge and basically follow up. These are the three components of the KMCs. And out of these three, which is the hallmark feature? The hallmark feature is the KMC position or skin to skin contact. Skin to skin contact, right? So these are the three components of the KMCs. Then particularly I have summed up certain lines regarding the preterm child, right? Because preterm child is mostly nowadays, which is very important from the MCQs. First line, what it says, if required at the neonatal resuscitation, what should be the initial concentration of oxygen? The initial concentration of oxygen should be 21 to 30%. In a term child, if you compare, the initial concentration of oxygen is the room air. Room air. But here we say particularly in the term child, it is room air, but in a preterm child it is 21 to 30% oxygen. Second, we say there is a continuous murmur, and this continuous murmur is in the left infraclavicular area or upper left sternal border. You are also given no cyanosis, you are given wide pulse pressure, your answer is PDA, right? If you simply think of, this is your aorta here, this is your pulmonary artery, here is the ductus arteriosus. So you get basically a continuous murmur, and that continuous murmur will be present either in the upper left sternal border or in the left infraclavicular area. Continuous murmur, that is the important thing to be remembered. There is no cyanosis which is present, and this is the wide pulse pressure. Wide pulse pressure, right? So your answer is patent ductus arteriosus. Patent ductus arteriosus. Complication of the intraventricular hemorrhage. And the complication of the intraventricular hemorrhage is hydrocephalus. Hydrocephalus, right? That is basically the complication we are saying is 100% oxygen we are using if the child is being given chest compression. Please don't confuse anything, right? We are given 100% oxygen when the child was being given chest compression. Here we are saying is initial concentration of oxygen, initial, right? So initial basically means you're starting with bag and mask. So when you're starting with bag and mask, what is the initial? Clear? That is the thing we have told here. Complication of intraventricular hemorrhage is hydrocephalus, and which type? This is non-obstructive hydrocephalus. Non-obstructive hydrocephalus. Then is cranial ultrasonography for IVH is routinely recommended in the preterm child less than 32 weeks of gestation. Less than 32 weeks of gestation. That is important, is right. Why? Because the most common cause of IVH is the spontaneous hemorrhage. Spontaneous hemorrhage. So we need to basically do the cranial ultrasonography in almost all preterm child which are less than 32 weeks of gestation. Then is antenatal steroids we are giving in the preterm child. They decrease the incidence of HMD, they decrease the incidence of NEC, they decrease the incidence of IVH, right? Then is physiological jaundice. It can persist up to how many weeks in a preterm child? That is 3 weeks. But in the term child, physiological jaundice persists up to 2 weeks. It persists up to 2 weeks. Hyaline membrane disease will usually manifest within 6 hours of birth. 6 hours. and maximum is 24 hours. HMD will never manifest after day 1. It will never manifest after day 1. But apnea of prematurity, this manifests between 2 to 7 days after birth. This will never manifest in the initial 24 hours. Right? That is both are the respiratory disorders you get in a preterm child. HMD that manifests in the first 24 hours and AOP usually manifests between 2 to 7 days after birth is. Right? So this was just a compilation of the various problems you can get in a preterm child, and you can simply remember them like this here. Clear? Then this slide tells you about the risk factor of 3 common things which you can get in neonatology. What are the risk factors for NEC? What is the risk factor for neonatal sepsis? What is the risk factor for PPHN? So in the NEC there are the 4 risk factors, and the most important risk factor is the prematurity. Most important risk factor is the prematurity. Second risk factor is formula feeding. Third risk factor is PDA. Fourth risk factor is indomethacin. So these 4 are particularly the risk factors for the NEC. Neonatal sepsis. Neonatal sepsis, particularly the risk factor is gestation less than 37 weeks. This again becomes the preterm child. Rupture of membranes more than 18 hours and the low birth weight, right? And these all are the risk factors for the early neonatal sepsis. And if you consider late neonatal sepsis, in the late neonatal sepsis, the risk factor is hand contamination. It is the hand contamination, right? Then here we take off PPHN, persistent pulmonary hypertension of the newborn. One risk factor is again premature closure of ductus due to maternal NSAID exposure, right? And this question has already been asked in NEET PG, that if the mother has been given NSAIDs, what complication can be seen in the child? Your answer is particularly PPHN. Second is the lung hypoplasia, which can be seen in oligohydramnios or congenital diaphragmatic hernia, right? Third is the parenchymal lung disease, meconium aspiration syndrome, respiratory distress syndrome, and pneumonia, right? So in a single picture, I've tried to cover the risk factors of all the 3: NEC, sepsis, and the PPHN is. Clear? Thank you all. Thank you so much. Hemorrhagic disease of the newborn. Hemorrhagic disease of the newborn basically because of the vitamin K deficiency bleeding. And this can be early onset, classical onset, and the late onset. In the early onset, a child is having hemorrhage within the first 24 hours. So why a child is having hemorrhage in the first 24 hours? Because mother was treated with certain hepatic enzyme inducer drug in pregnancy. And this hepatic enzyme inducer drug, they inhibits with the carboxylation of clotting factor 2, 7, 9, 10 by vitamin K, right? So these drugs can be particularly, the simple can be phenytoin, or the mother was taking the rifampicin. Mother was particularly taking the rifampicin. In the classical, it is basically presenting between the 2 to 7 days after birth. The child was delivered at home. The child did not receive injection vitamin K. That is one thing. And child is on exclusive breastfeeds, and which is the most common vitamin deficient, which is the most common vitamin deficient in the breast milk. And the most common vitamin deficient in the breast milk is vitamin K, right? So this is the classical we are talking of. Late onset. Late onset is seen between 1 to 6 months. And in the late onset, this is because of the fat malabsorption. Fat malabsorption. Anything which will cause fat malabsorption will lead to vitamin K deficiency. That can be cholestasis, malabsorption of vitamin K, which can also be seen in cystic fibrosis, and A beta lipoproteinemia. Right? So just I've tried to cover here what is the hemorrhagic disease of the newborn is. Moving on to again an important topic, infant of diabetic mother. Right? Now in an infant of diabetic mother, due to maternal hyperglycemia, there is one fetal hyperglycemia, and this fetal hyperglycemia will lead to the fetal hyperinsulinemia. fetal hyperinsulinemia, right? So what can be the effect because of insulin? The insulin is causing the intrauterine growth, so there will be macrosomia or large for gestational age. Insulin is more, this insulin can lead to the hypoglycemia. Then insulin is antagonist to cortisol. Insulin is antagonist to cortisol, so this can result in surfactant deficiency. Insulin stimulates erythropoietin. So if erythropoietin is increased, this will result in polycythemia. And if there will be polycythemia, the viscosity will be increased and this will result in the renal vein thrombosis. Apart from this, insulin will cause increase in the heart size. So which is the most common finding in heart in infant of diabetic mother? Most common finding. The most common finding we say is the cardiomegaly, which is followed by hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy, which is reversible. So you don't need to do anything here. This is hypertrophic cardiomyopathy, which is reversible. Then is the caudal regression syndrome. This occurs due to hyperglycemia and this is the most specific defect. So the most specific defect we see is the fetal hyperglycemia, which is the most common congenital heart disease. The most common congenital heart disease is the VSD. In the TGA, it is the most specific congenital heart disease. Most specific congenital heart disease. There is small left colon syndrome, due to which there is history of delayed passage of meconium. History of the delayed passage of meconium, right? This is particularly this. PFIC, Dr. Prathmesh, is not due to complete obstruction. PFIC 1, 2, 3, the receptors are being affected, right? That is particularly we teach in the regular batches go on for. This is a simple algorithm we have given and this is helpful for you to understand the causes here, right? Now here we talk is particularly the reflexes. Now in the reflexes what I have taken is what are the reflexes present at birth and what are the reflexes which are not present at birth. Doll's eye reflex is present at birth and already the question has been asked, this is physiological if it is present up to which week of age? Doll's eye reflex is physiological up to 2 weeks of age. So what we mean to say, if the doll's eye reflex is present beyond 2 weeks, this is pathological. Placing and stepping reflex. What we mean to say, can a child walk at birth? Yes. You take a newborn child, you make the child stand, the child will walk. That is the placing and stepping reflex. And this placing and stepping reflex disappears in 6 to 8 weeks. This disappears in 6 to 8 weeks. So why it is present at birth? What the concept says, the child is mostly in the vertex presentation. Child walks like this in the uterus. This helps in the descent of the uterus. So this placing and stepping reflex is present at birth. Babinski sign. This Babinski sign is positive at birth and it is positive up to 2 years of age. This is positive here and this is positive up to 2 years of age. So in the single slide I've tried to give, remember this, doll's eye reflex, placing and stepping reflex, Babinski sign, all three are particularly positive at birth, right? Not present at birth, symmetrical tonic neck reflex, which is also called as the crawling reflex, which is also called as the crawling reflex, right? This is not present at birth. Parachute reflex. Parachute reflex appears at which age? Parachute reflex appears at 9 months of age. So this is also not present at birth. Landau reflex. And this Landau reflex, this appears in the 3 to 4 months of age. 3 to 4 months of age. So just I have given you an idea which reflexes are present at birth and which reflexes are not present at the birth, right? Just regarding here the reflexes. Then nowadays what one about the topic which is going on, that is the hydropsis. Hydrops. Now how do you define hydrops? Hydrops is defined by two or more than two abnormal fetal fluid collection such as ascites, pleural, pericardial or cutaneous edema. So what I want is, at least first thing you should remember the name definition of the hydropsis. So hydropsis is at least 2 abnormal, right? And in the cutaneous edema, it should be more than 5 millimeter. 5 millimeter. Now what are the causes of the non-immune hydrops? Causes of the non-immune hydrops. One is, first cause is cardiovascular, and that is the most common cause. Most common cause, and in this it is the supraventricular tachycardia. Supraventricular tachycardia, which is the most common cause is. Second cause is hematological, which includes alpha thalassemia, G6PD deficiency, red cell enzyme deficiency. Third is infections, parvovirus B19. Fourth is chromosomal disorders, which includes all the 3 common trisomies 21, 18 and 13 and the Turner syndrome. And fifth and the last is the thoracic, which includes the problem in particularly lungs, CCAM, congenital cystic adenomatoid malformation of lung and pulmonary sequestration. And take my point, this is something important to be remembered. Causes of non-immune hydrops, and please remember the most common cause is the supraventricular tachycardia. Is the most common cause is supraventricular tachycardia, right? Now a question to all of you. Out of the following, hydrops fetalis is least likely to be presented? I want answers from you. I want answers from you. What should be the answers here? Least likely to be present here. Right, the answer is beta thalassemia, because when a child is born, child is having the fetal hemoglobin, and the fetal hemoglobin means composition is alpha and gamma chains. Beta chains comes after 6 months of age. So if they particularly come after 6 months, beta thalassemia will not present with the hydrops fetalis, right? So the right answer here is the beta thalassemia. Is clear? Lastly, here one chapter was added in the Nelson in neonatology regarding the dysmorphology. That is basically the defect in the morphology, and basically I want you to know that you should remember what is the meaning of the word sequence, what is deformation, and what is a syndrome is. So basically we want to remember these 3 things. Now first is a sequence. Sequence, what it means is there is some single error and that results in subsequent defect. So it is something a sequence. Initiation is there, right? So there is a single error in the morphogenesis that results in a series of subsequent defects. For example, Pierre-Robin sequence. So in Pierre-Robin sequence, what happens is there is mandibular hypoplasia, small jaw. So due to small jaw, the mandible is basically not developed. So the tongue falls down or the tongue becomes posterior. That is glosstosis. Glosstosis. And if the tongue is posterior, what happens is basically the palate is not able to fuse. So there is a defect in the posterior part of the palate. We see it to be the cleft palate, right? So this is something we say is the single error in morphogenesis, and one of the example you need to remember is the Pierre-Robin sequence. Then is the mechanical force that alters structure of the intrinsically normal tissue. That is what we call deformation. And you all need to remember what can happen due to oligohydramnios. Oligohydramnios can result in dislocated hips, it can result in equinovarus foot deformity, and it can result in pulmonary hypoplasia. It can result in pulmonary hypoplasia, which is the most common cause of death in oligohydramnios. And the question can be, which is the most common cause of death in autosomal recessive polycystic kidney disease? Autosomal recessive polycystic kidney disease, renal genesis, renal problem, oligohydramnios causing pulmonary hypoplasia, which is the most common cause of the death is, right? Then there is appearance of multiple malformations in unrelated tissue that have a known unifying cause. That is what we call as the syndrome, right? So I've tried to cover here some important points related to neonatology so that you can revise in a very short time, right? This is what we say here is. Now from the neonatology, now I move to the part of the nutrition. So we'll be talking of now the nutritional disorders. Clear? In the nutritional disorders, one is moderate acute malnutrition, which you call MAM, and one is severe acute malnutrition, which we call SAM, right? So what is the criteria for the MAM? In the MAM, weight for height, what we say is Z score is -2 to -3. And in the SAM, we say Z score is less than -3. Z score is less than -3. Mid upper arm circumference. In MAM, it is 11.5 to 12.5 centimeter. In the SAM, this is less than 11.5 centimeter. Pedal edema, here it is absent. And here what we say, the pedal edema is present, right? So we say here the criteria is one for of the MAM, and two, if you ask me particularly which is important, MAM or SAM, always remember MAM is important. So till in the NEET PG, what we expect right now is you might get questions on the MAM, moderate acute malnutrition. Then what are the signs of dehydration in a severely acute malnourished child? And the important I have taken like this, non-reliable and reliable. In the non-reliable, skin turgor is one thing, because already in a malnourished child you get is the loose folds of skin, right? So you can't take them to be a reliable sign. That becomes a non-reliable sign. Second is the mental state, because already you study there is psychomotor changes in kwashiorkor, right? So this becomes a non-reliable sign. Third is the mouth and tongue. That becomes a non-reliable sign, because in a malnourished child you might get glossitis. That can give you appearance of shiny tongue. You might think that the hydration is adequate, but the hydration might not be adequate. Glossitis can be due to vitamin deficiencies. So these three are considered to be the non-reliable signs is. Then is the urine output, right? In the reliable, and this is the most reliable sign. This is the most reliable sign. Weak or absent radial pulse, prolonged capillary filling time, recent sunken eyes. Remember recent, not sunken eyes. If it is only given sunken eyes, that is not a sign, because one who is not getting enough to eat, eyeballs will be sunken only. You can't take it to be a reliable sign. Increased thirst, reliable sign. History of diarrhea, this is reliable sign, right? So this is what we say is the non-reliable signs, and this 6 we say is the reliable signs is. Fluid therapy in severe dehydration. Which fluid has to be given? Now one is a normal child and one is a SAM child. In a normal child, if it is severely dehydrated, you go for the ringer lactate or the normal saline. But in a SAM child, you give is the 5% dextrose plus ringer lactate, or you give is half normal saline plus 5% dextrose. So you need to remember what is the initial fluid of choice in severe dehydration. That is there. Now what is the duration of initial 30 ml of fluid? Now when you study in a normal child, what you study, if the child is less than 1 year, you give 30 ml of fluid in 1 hour. And if it is more than 1 year, you give in 30 minutes. That is what you study is. But in a SAM child, this much of the fluid is given in 2 hours. This is something we expect the MCQ is, right? This is something we say here is. Clear? So we say here 2 hours is there. Clear? Please remember this, and this something is important. You might be given a severe acute malnourished child, and you might be thinking the plan C according to IMNCI, which we are giving in severe dehydration, but that is for a normal child. This is not for particularly this child here is, right? Then we talk is the treatment of vitamin A deficiency in the international units. We are talking less than 1 year. Less than 1 year, this is 1 lakh units. Next day also 1 lakh units. After 2 weeks also 1 lakh units. Right? If the child is more than 1 year, but the child should also be more than 8 kgs. Child should be more than 8 kgs. Here we say 2 lakhs international unit. Here we say 2 lakhs international unit. Here we say 2 lakhs international unit. Right? And what is to be remembered now? This is 1, 2 and 14 days. This is 1, 2 and 14 days, not 0, 1, 14. Right? And if the child is SAM, you need to give this doses again every month till the SAM resolves. This is something which has come new, right? In a SAM child, you will be giving these 3 doses also, but you will also give the same doses every month till particularly this resolve, right? So this is what we are saying is the treatment of vitamin A deficiency. Now this again picture is very, very important. You are talking of non-nutritional rickets, which basically means is vitamin D resistant or refractory rickets. Vitamin D resistant or refractory rickets. On one side there is increased PTH, one side there is normal serum phosphorus and normal PTH. Here it is decreased serum phosphorus and normal PTH, right? Increased PTH. Now what do you mean by refractory rickets? Refractory rickets simply means it cannot be corrected by giving cholecalciferol. It does not mean that it cannot be corrected at all. What it simply means is it cannot be corrected by giving cholecalciferol. Increased PTH, you need to remember chronic renal failure. You need to remember VDDR 1A, 1B, 2A, 2B. Right? This is particularly the conditions is. Normal serum phosphorus and normal PTH. You need to remember only one condition, that is distal renal tubular acidosis. Distal renal tubular acidosis. Decreased serum phosphorus, normal PTH. Decreased serum phosphorus, normal PTH. One condition you need to remember is proximal renal tubular acidosis. Second, you need to remember increased amount of fibroblast growth factor 23, which can be seen in X-linked hypophosphatemic rickets. X-linked hypophosphatemic rickets. This can be seen in McCune-Albright syndrome. This can be seen in McCune-Albright syndrome, right? And take my words, by this table you will be able to solve many MCQs regarding the rickets, where the PTH is increased, where the phosphorus and normal PTH is there, where there is decreased serum phosphorus and the normal PTH. And a line which you should always remember is a normal PTH level. Normal PTH level excludes the diagnosis of vitamin D deficiency. It's a very important line regarding the MCQs of the rickets. If you are being given the rickets question and you are being given normal PTH, this cannot be vitamin D deficiency. It has to be some other cause, but it will not be the vitamin D deficiency. Clear? So this is what we are saying is non-nutritional rickets, that means refractory rickets, and refractory rickets means there is no response to cholecalciferol. There can be 3 causes for this, where there is increased PTH, one cause is this, where there is normal serum phosphorus, normal PTH, and this is decreased serum phosphorus, normal PTH, right? Then here I have tried to discuss here the difference between the marasmus and kwashiorkor, not from the routine, some points. One is the triceps skin fold, and this triceps skin fold actually is a measurement of subcutaneous fat. That is a measurement of subcutaneous fat. So in marasmus there is loss of subcutaneous fat. So this is less than 5th percentile here. This is, you can say, more than 50th, because no loss of subcutaneous fat. Serum albumin, as in the kwashiorkor, there will be protein deficiency. This is decreased here, but it is not decreased here. What happens to the face in the marasmus? In the marasmus, this is the simian phases, which you also cause monkey faces, you also cause old man faces, and you will get when there is loss of buccal pad of fat. In the kwashiorkor, we get is the moon-like faces, as there is decrease in cortisol binding protein. And due to decrease in the cortisol binding protein, there is increase in the free cortisol level. And this free cortisol level gives some moon-like faces. If you see in the skin here, loose and wrinkled, and this is again due to loss of subcutaneous fat. Due to loss of the subcutaneous fat. But in the kwashiorkor, you get is the shiny and edematous, because due to edema that is there. And secondly, you can get is flecky pain dermatitis, which is considered to be pathognomic here. This is considered to be the pathognomic here, right? That is the flecky paint dermatitis. Clear? So this was regarding some topics of the nutritional disorders, which I consider to be important for your NEET PGs. Now going on to the intrauterine infection. And in certain intrauterine infection, you basically get the triads, three features which are the common is. So if we first consider congenital toxoplasma. In congenital toxoplasma, you get is hydrocephalus, chorioretinitis, and intracranial calcification. You can just see these are the three things which you are particularly getting there. In the congenital rubella syndrome, again you get is three things. One is SNHL, one is cataract, and third is patent ductus arteriosus, which is more common than pulmonic stenosis. More common than pulmonic stenosis. Then is parvovirus B19. In the parvovirus B19, again it is a triad. It is congenital anemia, it is myocarditis, it is hydrops fetalis. Right? So you can easily remember these three important features. And a parvovirus B19, you had a question in the AIIMS exam. Right? So you can just remember these three triads, which what we see here is. Moving on, you get a child of microcephaly. And last in the NEET PG, you had a question, microcephaly periventricular calcification. So we are talking on the same lines here. There is microcephaly, and microcephaly there can be two causes. One is cytomegalovirus, one is congenital Zika syndrome. Right? So basically we are saying is this is the two things here. In this cytomegalovirus, what you get is periventricular calcification, you get is sensory neural hearing loss, you get is microophthalmia. So that is basically you get in cytomegalo. In the Zika syndrome, there is microcephaly, but that is intracranial calcification. Not periventricular, this is intracranial. Then in the ocular findings, please remember they affect the posterior segment. This is something which I expect if they ask you Zika virus, they can ask you this thing. That means particularly the retina is affected. So that is affecting the posterior segment. Then there is congenital contractures, CTEV, right? Contractures are seen in the congenital Zika syndrome. Is clear? So this is what you get. Microcephaly, you can easily think of two causes and you can easily solve the MCQs. Now in the skin lesions, there are again two things which you can cause the skin lesions. One is herpes simplex virus, one is varicella zoster virus. So one can be the herpes simplex and one is particularly the varicella zoster. And the herpes simplex, this is basically herpes simplex virus 2. This is herpes simplex virus 2. And this is mainly intrapartum transmission. That is mainly intrapartum transmission from the mother genital tract at the time of delivery. This can present as SAM disease, skin eye mucous membrane disease. This can present as encephalitis, and the point here is it can affect any lobe of brain. This can affect any lobe of brain. While in HSV1, this only affects temporal lobe. Here it can affect any lobe, and third is disseminated infection. Then is congenital varicella. If the mother gets varicella in the first and second trimester, that is primary varicella, the child can have intrauterine infection. what are the features you get for? You get is limb hypoplasia, you get is cicatricial skin rash which is present in dermatomal distribution. Please do remember cicatricial skin rash. Cicatricial skin rash. And cicatricial means this is associated with fibrosis. This is associated with fibrosis. Neonatal varicella. Right? In the neonatal varicella, this will not present like a chicken pox. This neonatal varicella will present with the, say, involvement of the organs, visceral dissemination, and there is involvement of the brain, lungs, liver. Brain, lungs, liver, and it can present with skin vesicles which are hemorrhagic, right? So you can easily revise, because in both of them the treatment in the neonatal varicella and herpes is acyclovir. So I've tried to taken like this. The skin lesions can be seen in both of them, but there will be no fibrosis in herpes, but there will be fibrosis in the varicella zosteris, right? Now this is an important thing where the students sometimes get confused. When to give varicella zoster immune globulin, we are talking of Varizig in a newborn. Varicella zoster immune globulin, right? So if you see what is the most dangerous period for neonatal varicella, the most dangerous period we say if the mother gets varicella 5 days before delivery to 2 days after delivery. So in the most dangerous period, you will definitely give Varizig. So what we say, mother develops chickenpox within 5 days before delivery or within 48 hours after delivery. So if the mother is getting chickenpox here, you basically go for the giving the Varizig, varicella zoster immune globulin. Second, a child is there which is more than 28 weeks. 28 weeks. Mother never had chickenpox earlier, or mother is not having serological evidence. What the concept says, the antibodies are mainly transferred from the mother to the child in the third trimester. So if a child is born less than 28 weeks and this child is exposed to a person having varicella, right? So what we assume, even if the mother had chickenpox, if the mother had vaccination, mother will be having antibodies, but these antibodies will not be transferred to the child. So in that case, Varizig has to be given. But if a child is more than 28 weeks, he is exposed to a person having varicella, right? What you will ask the mother, did you had chickenpox before, right? Did you took the vaccine? Or you can measure the antibody titer. If they are present, no need to give the Varizig. Clear? So this is something important to be remembered like this. We are talking of the indications for giving the Varizig in the neonates. Clear? So this is what we say here. I hope I have tried to cover here all the intrauterine infections here. We have covered here the intrauterine infections. Going on to the part of the genetics. Now in the genetics part, what is important basically is nowadays screening part. Screening. This has suddenly come up, right? In the Down syndrome screening, Turner syndrome screening, this is something, a chart is being there, we monitor for different disorders. So in the Turner syndrome, there are certain things which particularly needs to be remembered. Now you basically screen for growth and you will measure the height at every visit because it is ultimately a cause of the short stature. In the skeletal, it is scoliosis or hip dysplasia. For this scoliosis, you will screen at 5 years of age and hip dysplasia every visit from birth to 12 months. Sensory neural hearing loss. That is, you need to screen at birth. Even if you don't remember the timings, need not worry at all. Please do remember this. What is seen for what we screen in Turner syndrome. That is important is. Then the celiac disease and inflammatory bowel disease. You need to screen every 2 to 5 years after 3 years of age. Right? Then we say is cardiovascular defects. You need to diagnose particularly at birth. You can add here basically at birth. Please add here cardiovascular defects at birth. Right? Renal defects. This is particularly a diagnosis. Hypothyroidism, you start screening from 4 years, and ovarian failure, you start from 10 years. Now, what is the important thing you need to remember here? Which particularly hearing loss is seen. This is SNHL which is seen. Then which particularly a thyroid problem can be seen Hashimoto thyroiditis. We had a question last time in the AIMS exam. It was basically asked what all problems can be seen in Turner syndrome. So Turner's, this is something important to be remembered, and particularly remember here also in Klinefelter syndrome. In Klinefelter syndrome, there is increased incidence of SLE. There is increased incidence of SLE. Why this line is important? SLE is normally increased in females, normally increased in females. Klinefelter is the only syndrome where this is increased in males, right? So please do remember this point. In Klinefelter syndrome, there is increased incidence of SLE, right? Now this is basically the 4 pictures we have given here regarding the genetics part. What can happen to the changes in the hand? Now if you first see here, this is basically showing is the overlapping of digits. Tracks 1 gene, very good. You are remembering the notes, really good. Overlapping of the digits, and overlapping of digits is a feature of the trisomy 18. That is the Edwards syndrome. That is the Edwards syndrome. This is showing is a single transverse palmar crease. That is the simian crease. Single transverse palmar crease, that is the simian crease, which is seen in the trisomy 21. And this can also be seen in the Cri-du-Chat syndrome. Try to chat with that, but this can be seen in Cri-du-Chat syndrome. This is what we are showing is the polydactyly. Here we are showing is the polydactyly, and polydactyly is something which is seen in the trisomy 30. Trisomy 30. This is what we are showing here is the lymphedema. This is the lymphedema, and lymphedema can be seen in the Turner syndrome. This can be seen in the Turner syndrome, right? So basically we just need to revise what all changes can be seen in the hands. That is the 4 things we are seeing here. So moving on to the foot. If we move on to the foot, here what we are saying is there is increased gap between the first and the second toe. We are saying is increased sandal gap. And in the increased sandal gap is a feature of trisomy 21. Trisomy 21. Here we say is particularly, this is, if you see, this is the short 4th metatarsal, right? And similarly in the hand, it can be short 4th metacarpal. And these are the features of the Turner syndrome. This is a feature of the Turner syndrome. This is the rocker bottom foot. This is the rocker bottom foot. And this rocker bottom foot is the Edwards syndrome. Edwards syndrome. Many students are getting tired. Please don't be tired. Hardly I need 15-20 minutes more and we'll be able to revise. Whenever you get tired, just think of, as I always say in the class, we are all not greedy fellows. We all want a single PG seat is. And what my genuine advice to all of you is, start praying to the God from today only. And say to the God, hey God, I am doing the hard work. Politely and quietly give me a single seat. I am not a greedy fellow. But the problem is you all pray on the day of exam. And on that day, everyone is praying. Your prayers go in waiting list. Please don't let your go into prayer into the waiting list. So start praying to the God. Just take your hands like this, pray to the God, and He will answer all your prayers. Clear? I hope so you will listen to my advice. And please, not tired at all. You should not be tired. Clear? So here what we are saying is now, ejection systolic murmur is being present, right? We are saying is ejection systolic murmur. Clear? And we are having 2 pictures which are being given. Now in this, if you can see here, we are having a so-called triangular faces. The chin is small, right? And that means again it is a triangular face, and this picture you need to remember is the Ella-Gill syndrome. Ella-Gill syndrome, which we teach you along with the neonatal cholestasis. Ella-Gill syndrome. Involvement of JAG1 gene. involvement of JAG1 gene, it is chromosome number 20. Chromosome number 20, right? And here if you consider the congenital heart disease, it is pulmonic stenosis. And this pulmonic stenosis is going to give you a ejection systolic murmur, right? Now if you see that picture, particularly that picture, if you are being given a picture, mouth is wide open, teeth are not there, there is microdontia or there is endontia. There is microdontia or there is endontia. You should practically think this is Williams syndrome. This is the Williams syndrome. And in the Williams syndrome, you get is the supravalvular aortic stenosis. You get is the supravalvular aortic stenosis, right? And again that is going to produce which murmur? Ejection systolic murmur. So you can easily get two pictures we have given, and here you can remember like this, that both will be having which picture. So these are the photographs we have given, and the murmur you can easily correlate this, right? Now there are certain concepts, just one liner to be just mug up regarding the weight. If you consider weight, by 5 months the weight doubles and by 1 year it triples. Height, the important question, half of the adult height is at the age of 2 years or 18 to 24 months. Upper segment lower segment ratio is equal to the age of 10 years. Head circumference, at the end of second year it is 90% of the adult size, and at the end of 12 years adult size is attained. You can simply remember, at the end of second year it is 90%, left is 10%, which requires another 10 years. So 2 plus 10 is 12 years. So adult size is attained at the age of 12 years. If you consider chest circumference at birth, we all know OFC, head circumference, is more than chest circumference by 3 centimeters. So just important things to be remembered regarding the growth part. Now we talk here the milestone part, and this is the only thing which I am asking to you. This all will be seen at which age? This all will be seen at which age? Right? So if we particularly say here, the child is doing the waves bye-bye. Child is waving bye-bye. Now in the second picture, if you see, there's a toy. The toy was covered by a cloth. Now the child himself is removing the cloth. You are saying to the child, by covering the cloth, that the toy is lost, that magic lost. Child will say, no magic, no loss, toy is there. And this is the sense what we call as object permanence. Object permanence. And this is what we say the child claps. And all these three milestones comes at 9 months of age. This comes at 9 months of age. Simply remember, when the child comes for the measles vaccine for the first time, he waves bye-bye for the first time. Bye-bye and first dose of measles. And after the measles vaccine, he claps. You can just remember these two things like this. You will never forget in your life, right? And 9 months, this is something important. All these three sense which to be remembered here. Now, jargons. These both are different one actually. The child jargons at the age of 15 months. The child jargons at the age of 15 months. Jargons means there are certain unintelligible words which are not present in the dictionary, but they are present in the community. That is what we call as the jargons. For example, in North India, we say mum. Mum means water. Similarly, right now the jargoning word is going on moon. Moon means child is asking for mobile phone. That is the jargoning now. Child can understand a story. Understand a story is at the age of 2 years. So if you were telling a child stories before that, they were of no use. So if you want to make story in front of a child, child should be at least 2 years. Child can use past tense at the age of 4 years, use future tense at the age of 5 years. So if you just want to ask a child what you want to become when you grow old, at least ask after 5 years, because child can only use future tense after the age of 5 years. Then is handedness. Handedness usually develops at 3 years of age. Handedness usually develops at 3 years of age. Now, if there is early handedness, mother says is only picking up of the object with one hand, early handedness. Early handedness is indicative of spastic hemiplegic type of cerebral palsy. If there is early handedness, it is indicative of the spastic hemiplegic type of the cerebral palsy. Right. Now, in the last, I have taken specifically vaccination in a child with cancer, vaccination in a child who was on steroids, vaccination in a child in which bone marrow transplantation has been done. Right? These are three specific things what I feel like you people should remember. First, we talk of a vaccination of a child in a cancer. If a child is on basically chemotherapy, what we say, live vaccines are contraindicated during and up to 6 months after the end of chemotherapy. Right? You should not give, when a child is on chemotherapy, live vaccines should not be given. And even if the child has completed the course of chemotherapy, you should give after 6 months, which is the only vaccine which is recommended. The only vaccine which is recommended is the annual inactivated influenza vaccine. This annual inactivated influenza vaccine is the only vaccine which is recommended for children during chemotherapy. Right? Thus, the sibling can be given the vaccines. Sibling immunization should continue uninterrupted. Only the point is, you should not give oral polio vaccine to the siblings. This should be substituted by the injectable polio vaccine. This should be substituted by the injectable polio vaccine. Non-live vaccines, if you want to give, they are best given after 6 months from the end of the treatment, so that you can give the immunity. So out of the 4 particularly, what you need to simply remember is one thing: if a child is on chemotherapy, vaccine should be given after 6 months. Vaccine should be given after 6 months, right? Then is a child had a bone marrow transplantation. So now here we are talking of vaccination in a hematopoietic stem cell transplant, right? In a hematopoietic stem cell transplant, you consider, because when you made the bone marrow transplant, the child was made immunodeficient. So you will consider it to be a unimmunized child. You will consider it to be a unimmunized child because they have lost all the responses. So what needs to be given? 3 doses of tetanus or diphtheria should be administered 6 months after bone marrow transplant. The same with the chemotherapy, but this needs to be given, say, 3 doses. But if the child is more than or equal to 7 years, you can give only Tdap followed by 2 doses of Td. Apart from this, you need to give injectable polio, Haemophilus influenzae, hepatitis B. You need to give pneumococcal conjugate vaccine, right? Although somebody may find particularly what is not to be done, a simple thing which has come in the literature, I have taken because IAP has just published the recent changes in vaccination, right? And sometimes this question might be asked, I have taken in the hematopoietic stem cell transplantation. This is particularly a child is on steroids. What to be given, what not to be given. That will depend upon what is the dose of the steroid and for how long it was particularly given. So if you consider here, the dose was very less than 2 milligram per kg, and the child is less than 10 kg or less than 20 milligram per kg, you don't think any immunosuppression is there. And the same applies here also, the same doses if they were given for less than 2 weeks. The same applies here also. In both of them, what we say, there is no immunosuppression. So they can be given all vaccines. And what is important is, if you remember the third part of the table, child is on more than 2 milligram per kg, more than 2 milligram per kg, or more than 20 milligram per kg if it is more than 10 kg, but he has received steroid. He have received steroid for more than 2 weeks. He have received steroid for more than 2 weeks. We are not giving any live vaccines till 1 month after stopping these steroids. We are not giving no live vaccines till 1 month after stopping the steroids. Clear? So this is what we say here is, this is to be remembered. Chemotherapy after 6 months, bone marrow transplantation after 6 months, high dose steroid given for more than 2 weeks after 1 month. Remember this. Last table I have taken particularly, you had a question in the AIMS exams also. This is the vaccination in the immune deficiency. First we are saying here is defect in phagocytic function. Defective in phagocytic function. One is chronic granulomatous disease. There is NADPH oxidase deficiency or Chiari-Higashi syndrome, leukocyte adhesion defect type 1, type 2 and myeloperoxidase deficiency. Only the live bacterial vaccines are contraindicated. Live viral vaccines can be given. Live viral vaccines can be given. Right? Second we are saying is a child is having defect in B lymphocyte or T lymphocyte defect. B lymphocyte defect includes X-linked A gamma globinemia or Bruton, common variable immunodeficiency. T lymphocyte defect, severe combined immunodeficiency and D George syndrome. So if you consider in both of them, all live vaccines are contraindicated. But if a child is only having complement deficiency, no vaccine is contraindicated. In fact, what is recommended is meningococcal vaccine is recommended. Meningococcal vaccine is recommended. Clear? So this is what we say here is, right? So before ending, let's discuss certain 10 MCQs. I hope you will like them solving the MCQs here. If you are having the time, we will solve the 10 MCQs. Full term infant with birth weight 4.1 kgs is born to a female with insulin dependent diabetes mellitus. Child is not able to accept breastfeeds. On examination, blood sugar is 30. Out of the following, most likely pathogenesis of hypoglycemia is? Intrauterine passage of maternal insulin? Not at all. Diabetes mellitus? Not at all. Liver dysfunction? Not at all. It is increased insulin production by the infant. You absolutely dot on the, everybody's dot, right? Is giving the right answers. Very true. Very, very good. Moving on to the next one. Term child is born to a diabetic mother. Right arm oxygen saturation is 85%. Rest of the infant's vital signs including blood pressure are normal. On giving oxygen, saturation increases to 95% at 3 hours of age. There is no respiratory distress and a soft 1/6 systolic heart murmur is heard to the left upper mid-sternal border. Chest radiograph is normal. Most likely cause of decreased initial oxygen saturation is? What we want to say here? Why hypertrophic cardiomyopathy? We are saying is chest radiograph is normal. This is ruled out. Please rule out this. Right? We are giving is saturation is increasing. Clear? If the cyanotic heart disease is there, that will not increase the oxygen saturation. This is particularly ruled out. Right? So that is why particularly what the cause now becomes. The cause now becomes polycythemia. That is very well seen there. Clear? Because if it is surfactant deficiency, again the chest x-ray will not be normal. Why the chest x-ray is normal? Always I teach you in class, please follow the method of exclusion. Exclusion is important. Exclude. You are saying chest x-ray is normal. Exclude hypertrophic cardiomyopathy. Saturation is improving on giving oxygen. Exclude cyanotic congenital heart disease. Right? This is something excluded. So what is left here is the polycythemia. Follow the method of exclusion. Right? Maybe you think this is right or wrong. The aim is not to find out. There are two questions. One are factual, one is conceptuals. Conceptuals follow the method of exclusion. Please. Newborn had APGAR score of 4 at 1 minute. Positive pressure ventilation was started and now APGAR is 8 at 5 minutes. The significance of low APGAR at 1 minute of age is? Polycythemia, there is decrease in saturation. Because due to polycythemia, the viscosity of the blood increases, right? And due to the viscosity of the blood increases, this can result in decreased oxygen supply. Amplitude EG should be done. This should be EG to done assess neural damage? No. MRI brain, now the ABGAR is 8 at 5 minutes. And if the ABGAR is 8 at 5 minutes, this is normal ABGAR. This is normal ABGAR. And if you see HIE, what we say? ABGAR is less than 3 at 5 minutes. So this is not HIE. And if this is not HIE, this is not 2, 3 and 4. This is not 2, 3 and 4. Because amplitude EG, MRI and therapeutic hypothermia all is for HIE. And so what is left is now. This is left is now. Agreed? Please and please just look at the questions and you'll be able to solve the questions. Right. Moving on to the fourth one. Best parameter. Those who are saying this was perfect for NEC. Now I say this is best for the NEET PG. Best parameter to assess the neonatal resuscitation is heart rate. Out of the following, which is not a reliable mean to assess the heart rate in a newborn? Which is not the particularly mean to assess the heart rate? Best score for neurological exams in a newborn, you say, is the fetal pH. If you want to look for the HIE, you go for the arterial blood gas analysis. Cardiac monitor is reliable, auscultation is reliable. Out of these two, you should choose umbilical cord palpation more than pulse oximetry. This is according to the textbook of neonatal resuscitation. This is according to the textbook of neonatal resuscitation by American Academy of Paediatrics. What it says, if there is poor perfusion, your answer is pulse oximetry. But if it is not given, the answer is umbilical cord palpation. The answer is umbilical cord palpation. In preterm newborn, all are the potential benefits of delayed cord clamping except. In preterm newborn, all are the potential benefits of the delayed cord clamping except. Definitely these 10 questions I will post as PPT. I will get them uploaded on the app. Don't worry at all, please. The answer is absolutely right. Lower risk of hyaline membrane disease. Delayed cord clamping results in higher blood pressure, high blood volume, low risk of NEC, low risk of brain hemorrhages. But this cord clamping has nothing to do with the hyaline membrane disease. It has nothing to do with the hyaline membrane disease. Yes. Which of the following is an indication for pulse oximetry in a neonate? Which of the following is an indication for pulse oximetry in a neonate? This is all question from American Academy of Paediatrics neonatal resuscitation. Just I have taken the lines and I have made the question. And here particularly the answer is all of the above. You want to give supplemental oxygen, you want to start positive pressure ventilation, you want to confirm whether there is presence of central cyanosis. So we say here is all of the above is absolutely right. 4 days old on examination is found to have brisk Morrow's reflex. Out of the following, which can be a cause? What can be a simple cause for a brisk Morrow's reflex? I think you should all be able to answer this. What is the cause for the brisk Morrow's reflex? The cause for the brisk Morrow's reflex out of this is what? Hypoglycemia. Absolutely right. Hypoglycemia and stage 1 HIE. Stage 1 HIE, they both are the causes particularly, right? Stage 3, the Morrow's is absent. We are asking is the brisk is hypoglycemia. Here we are saying is 3 weeks child, exclusively breastfed since birth, came with complaints of persistent jaundice. Child is alert, afebrile, gaining weight, icterus present up to thighs, total serum bilirubin 11.5, conjugated bilirubin 0.8. 0.8 means this is absolutely right. Less than 1 is okay. Most appropriate management in this child should be what? What should be the most? Reassurance to the mother, because this mostly seems to be the breast milk jaundice. This seems to be the breast milk jaundice, nothing else to be done. Liver function test, ultrasound abdomen does not carry, right? Question language is this, but the answer is very, very simple here. You're all right here. Premature infants often cannot achieve an Apgar score above 6. Out of the following, what is the physiological reason for that? Out of the following, what is the physiological reason for that? The physiological reason for that is the immaturity of nervous system. Because in the Apgar score, you judge nervous system by two things. One is tone, one is the reflex, right? So you're not able to judge properly the nervous system, but you can judge respiratory system, CVS. So therefore the score, this again is a guidelines. American Academy of Pediatrics guidelines, Apgar score sometimes in preterm child normally can also be not above 6. So this is basically the answer is immaturity of the nervous system, right? Now this is the second last question. Out of the following, the least likely to be beneficial in decreasing the severity of respiratory distress in preterm? We are saying is least likely, right? So what should be the least likely? Dexamethasone decreases, early CPAP will definitely decrease, tocolysis will decrease. So what is avoidance of supplemental oxygen? Why? Right? Least likely to be beneficial, right? You should not avoid this particularly. And your last question, give me the answer to this. While replying this, please be very careful. 35 weeks neonate is delivered with thin meconium stained amniotic fluid. At birth, respiratory rate of 52, normal respiratory rate in a newborn 40 to 60 per minute, normal heart rate 120 to 140 per minute, and moving all four limbs. Out of the following, which is the best next management? It is given 35 weeks, no respiratory distress, no problem in heart rate. Still it is meconium stained. And if it is a preterm child with meconium staining, you should always rule out intestinal obstruction. You should particularly rule out intestinal obstruction, right? If there is intestinal obstruction, the meconium will come like this, and that can result in the meconium staining. Students mostly make a mistake. That's why I always teach preterm child meconium staining is no respiratory distress. That is always the intestinal obstruction is, right? So that's all from the Department of the Pediatrics. Dr. Siddharth sir has covered your very good part of systemic, and we have covered this part of general pediatrics. And coming in the ends, what just I want to say is you need to follow your dreams. And what you need to believe is dreams make you live, dreams make you give. Dreams make you feel, dreams are the zeal. Dreams to become true if you are really true. Dreams make you tense, dreams are the sense. With all problems faced, dreams are to be chased. Dreams are to be believed and follow them till you are relieved. For the dams from the Department of Paediatrics, this is Dr. Ashutosh Aggarwal. You can very well follow me here. This is saying bye-bye to all of you. All the best for your exams, right? I hope we have done justice. Me and Dr. Siddharth sir both have done justice to your whole part of pediatrics. Thank you all. Thank you all for joining us, right? Really, right? Hope all those who want to become pediatricians, their life, their missions, their aim should be fulfilled, right? Thank you.